Hello everyone. In today's lecture, we will see how to approach to a case of rheumatology. Mainly, this is the compilation of two chapters from Harrison, chapter 370 and 374, which mainly deal with rheumatoid arthritis as well as spondyloarthritis. But I have compiled both of these chapters so that whenever we get any patient with complaints of musculoskeletal system involvement, how we have to approach step by step, that we will be learning in this lecture. So as mentioned, any individual presenting with musculoskeletal complaint, first we have to decide whether is it because of some systemic cause. For example, is there any hypothyroidism features or vitamin D deficiency, even fibromyalgia, or sometimes acute rheumatic fever leading to such musculoskeletal complaints. So based on these, we have to look for the other features and we can get the necessity investigations done to rule out systemic cause. Once this thing is done, then we can focus upon the rheumatological causes. Again, in rheumatological cause, decide whether it is acute focal inflammatory arthritis, because for this particular presentation, there are some other reasons like septic arthritis involving single joint majority of the times. Or is it due to trauma or some crystal induced arthropathies like gout or pseudo gout. So all these will fit into acute focal inflammatory arthritis. Suppose the individual is having symptoms for quite a longer duration of time, for example mainly more than 6 weeks of duration, then we have to keep the possibility of degenerative arthritis or inflammatory arthritis. In degenerative, mainly we will have the example of osteoarthritis, whereas in inflammatory long-standing arthritis, we have rheumatoid arthritis and spondyloarthritis. So we are mainly dealing with this particular section in this lecture. So first thing, as mentioned, if the symptoms are lasting for quite longer duration of time, first decide whether it is inflammatory or not. So the commonest differential will be degenerative arthritis or mechanical arthritis, which will be non-inflammatory. So how to differentiate both of these? Mainly for degenerative arthritis, as I have mentioned, remember about osteoarthritis, which is commonly seen in elderly population, for example age of more than 60 years. Whereas inflammatory arthritis like rheumatoid arthritis conditions are seen in the age range of 20 to 45 years. And one of the typical inflammatory feature will be morning stiffness, which is not seen in case of degenerative arthritis. Even if it is seen, it will last for less than 30 minutes. Whereas in case of inflammatory conditions, it will be lasting for ideally more than 1 hour. And remember, these degenerative osteoarthritis kind of conditions will worsen with activity. You might have seen elderly females presenting with knee joint related pain and all, which they will say it will worsen with walking or climbing stairs and all. So that indicates what? If we give more load on that particular joint, it will worsen the condition. That's why it is commonly seen in the joints which bear maximum load. For example, spine, hip, knee and all. So these are the common joints involved in degenerative arthritis. And the opposite thing will be happening in inflammatory arthritis, that is, they will improve with the activity. So these individuals will be having morning stiffness, and once they start doing their daily activities, they will feel relieved as the day progresses. Whereas the degenerative arthritis conditions will be increasing in intensity as the day advances because of repeated load on the damaged joints. And as the name indicates, in these inflammatory arthritis, there will be usually elevated inflammatory markers such as ESR and CRP, and these might be normal in degenerative conditions. And the examples we have already mentioned: osteoarthritis and mechanical back pain, whereas for inflammatory arthritis, rheumatoid arthritis and spondyloarthritis. And today we are mainly focusing upon this group, inflammatory arthritis. So now we have differentiated both of these and we will focus upon inflammatory arthritis now. But why we have compiled these two chapters? Because both of these conditions will share some common pathogenic cascade. So what is that? These individuals who are in the age group of 20 to 45 years commonly will be having some genetic predisposition. For example, they might be having HLA-DRB1, especially in case of RA, and HLA-B27 in case of spondyloarthritis. Such genetic predisposition will be there. Over that, some environmental insult will be happening. For example, through smoking or microbial infections, mainly to the GIT or genitourinary tract infections and all, they might trigger the further process. Otherwise, microbial dysbiosis, mainly the gut microbiome, if there is dysbiosis, that might also lead to the initiation of the pathogenic event. And remember, these are quite well-known genetic predispositions, but these are not the only reasons. There are numerous other genes which are responsible for the development of these inflammatory conditions. So once there is predisposition and environmental trigger has happened, there will be immune activation, like numerous immune-mediated cells will get activated. For example, CD4 T cells will be involved or CD8 T cells might be involved, leading to the release of numerous cytokines, commonly TNF-alpha, interleukin-1, interleukin-6. These are involved in RA pathogenesis, whereas interleukin-17, interleukin-23 are involved in spondyloarthritis pathogenesis, and even JAK is involved in the pathogenesis. Then, once these immune cells and the cytokines are activated, they will start cross-reacting with some self-antigens, mainly the synovial tissue in case of rheumatoid arthritis, and some other numerous articular structures like joints, entheses, tendons, even digits. These are all the self-antigens which are being targeted by all of these immunological response, leading to chronic inflammation and gradual structural damage in and around that particular articular tissue. So this is the common pathophysiology which applies both to RA as well as spondyloarthritis. Only thing is the gene which is responsible might be different, and the environmental trigger might be different, and it will also differ in the important cytokines involved for the development of disease. So there is some overlap as well as there is some dissimilarity. Now, after understanding the common pathophysiology, it is important to differentiate both of these conditions. So how to know whether it is rheumatoid arthritis or spondyloarthritis? First of all, if we focus on the incidence, mainly rheumatoid arthritis incidence is 0.5 to 1% of world's population, whereas this spondyloarthritis is seen in quite higher number, that is 2 to 3%. And if you compare it with the degenerative, that is osteoarthritis, where we will see up to 5% of incidence. So in the highest order of incidence, if we consider, osteoarthritis is quite very common, then comes spondyloarthritis, and the least common will be rheumatoid arthritis. And if we focus on the gender, RA is quite common in females than males in the ratio of 2 or 3:1, and it is quite reverse in spondyloarthritis, that is males are commonly affected in the ratio of 2:1, or sometimes it will be equal, that is 1:1. And the core pattern, if we focus, RA will be usually symmetric polyarthritis. What is polyarthritis? There should be minimum 5 or more joints involved, whereas spondyloarthritis is exactly opposite, we can say, that is asymmetric oligoarthritis, that is less than 4 joints are involved in spondyloarthritis. And in particular, there is a typical pattern also. For example, rheumatoid arthritis will affect the small joints of hands and feet, like metacarpophalangeal or proximal interphalangeal joint, even wrist. And one of the hallmark feature is it will spare DIP, distal interphalangeal joint. Whereas spondyloarthritis primarily targets the sacroiliac joint, spine, and the joints of lower limbs. And the other manifestations which will help us in differentiating both of these conditions are, as mentioned, there will be morning stiffness in both of these conditions, but the site will differ, like hands and feet are commonly involved in rheumatoid arthritis, whereas the lower back morning stiffness is common in spondyloarthritis, and both of these will improve with activity as the day progresses. Whereas if we focus upon the typical deformities seen in these conditions, there will be flexor tendon synovitis leading to trigger finger and the ulnar deviation because of subluxation of metacarpophalangeal joint and all. So here we can see that ulnar deviation, swan neck deformity or boutonniere's deformity, Z-line deformity. There might be piano key movement of ulnar styloid, as well as in lower limbs we can see flat foot. These are some typical features of rheumatoid arthritis. Whereas the deformities seen in spondyloarthritis are mainly reduced spine and neck flexibility, because these are commonly affecting the spine. Whereas due to involvement of thoracic spine, there will be reduced chest expansion. And one more point to be remembered is, in spondyloarthritis, thoracic and lumbar spine is commonly affected, and this particular thing is paired in case of rheumatoid arthritis. And here, if spine is involved, it will be cervical spine. Then after articular manifestations, if we focus upon some extra-articular systemic features, because these conditions are not just related to musculoskeletal system, they will commonly affect as systemic conditions. So what are those extra-articular manifestations seen in rheumatoid arthritis? Mainly, there might be some constitutional symptoms like fever, fatigue, malaise and all. And we can see normocytic normochromic anemia. Whereas in eyes, there will be secondary Sjogren's features like dry eyes, dry mouth and all. And in about 10 to 20% of the individuals, we can see rheumatoid nodules, that is firm, non-tender, subcutaneous nodules, mainly at the forearm or sacral prominence, Achilles tendon. So these nodules are also considered as extra-articular manifestations. Whereas lung involvement might be in the form of pleuritis, interstitial lung disease or pulmonary nodule. Sometimes in X-rays and all, we will be getting solitary pulmonary nodule and all. So in that case, we have to keep the possibility of rheumatoid arthritis and we have to search for the other features of RA. Whereas in heart involvement, it might present as pericarditis or pericardial effusion. Even it might manifest as vasculitis. For example, we can see purpura or gangrene of digits. Even vasculitic neuropathy might be the presenting feature. And in hemat, as I mentioned, there might be normocytic normochromic anemia or Felty syndrome. Even some lymphomas like diffuse large B-cell lymphoma can also be seen. But these are quite rare nowadays because of early diagnosis and the prompt treatment. Whereas in spondyloarthritis, it has some typical feature of involvement where it will involve varied tissues, and we are not sure what is the denominator for involvement of all of these. For example, commonly it will affect skin presenting as psoriasis. It might affect eyes presenting as anterior chamber uveitis and intestine mainly presenting as inflammatory bowel disease. So along with joints, there are typically 3 other extra-articular systems involved, which we can remember as skin. In Kannada, for eyes we will say kannu, and intestine. A kind of rhyme you can remember, skinnu, kannu, intestine. So these 3 extra-articular structures are involved in majority of the spondyloarthritis in different proportions. And just to enlist other manifestations, in lungs it might affect as apical, fibrotic or cavitatory lung disease. In heart, like conduction blocks or aortic valve insufficiency. In kidneys, because of chronic inflammation, it might present as renal amyloidosis or even IgA nephropathy might be the presenting feature. So whenever you are thinking of inflammatory arthritis and to differentiate RA and spondyloarthritis, just first search for this rhyme, skin, kannu, intestine. If it is involved, it is probably spondyloarthritis. If other than these, some other structures are involved, think of RA. This is one more clue towards differentiating both of these conditions. Since then, we are saying both of these conditions are almost similar in its pathogenesis as well as involvement of articular tissues. There might be deformities on long-standing disease as well as extra-articular manifestations. But where they will differ exactly? When it comes to rheumatoid arthritis, you will be hearing about terminologies such as rheumatoid factor and anti-citrullinated peptide antibodies and all. So we will understand these terminologies here. Whereas when you discuss about spondyloarthritis, we will mainly think about HLA-B27. So we will know what is the importance of these laboratory markers in each of these conditions. First of all, rheumatoid arthritis, if there is presence of these autoantibodies, we will call it as seropositive rheumatoid arthritis, which is commonly seen in about 3/4 of rheumatoid arthritis patients. Whereas the other 1/4, about 25% of the rheumatoid arthritis patients might not be having rheumatoid factor or these autoantibodies. So they are called as seronegative. And these autoantibodies will target citrulline containing peptides, mainly filaggrin, keratin, fibrinogen and vimentin. These peptides are mainly concentrated in articular tissues and they are also present in minimal quantity in the serum. That's why we will see articular manifestations as the common presentation, and because of their presence in the serum, it might affect any system. That's why it is a systemic disease, we can say. Coming to the rheumatoid factor per se, it can be of any isotype among IgM, IgA or IgG. But most of the laboratories are capable of detecting only IgM. That's why in some individuals, if they are predominantly having rheumatoid factor autoantibodies of IgA or IgG serotype, the laboratory might not detect it and we might label it as seronegative. So it's not like if the RA factor is negative, the individual is not having rheumatoid arthritis. So the sensitivity is low, we can say, as well as the diagnostic specificity is also low, because this RA factor is also found in some other conditions like SLE, Sjogren's disease, even hepatitis B or C infections, and at low titers it is also present in about 1 to 5% of healthy population. So just mere presence of rheumatoid arthritis factor does not confirm rheumatoid arthritis. Whereas the anti-cyclic citrullinated peptide antibodies, that is anti-CCP antibodies what we say, they have quite more specificity, that is about 95% specificity. So their presence majority of the times indicates rheumatoid arthritis. And also this particular autoantibody determines the worst outcomes. So if you focus upon the outcome deciding factors, presence of anti-CCP antibodies will be worst compared to the presence of rheumatoid factor. And if both of these are negative, that is seronegative rheumatoid arthritis cases will have better prognosis. So hope you have got the clear picture about these important laboratory markers. Coming to HLA-B27 in spondyloarthritis, it is the strongest genetic risk factor for the development of spondyloarthritis, but those individuals who are having HLA-B27, only a minority of them might develop the actual disease. So just mere presence of this genetic factor will not decide that the individual is definitely having spondyloarthritis. There should be some other trigger for the actual development of this disease. For example, gastrointestinal infections with Campylobacter, Salmonella, Shigella and all can trigger the pathogenic cascade, or urogenital infections with chlamydia, and commonly these might result in what we call as reactive arthritis or IBD associated spondyloarthritis. Whereas the gut or skin microbiome dysbiosis can lead to the development of psoriatic arthritis. And repeated mechanical stress on axial or peripheral tissues might also act as a trigger, leading to development of axial or even peripheral spondyloarthritis. So all these variants we will be dealing in the upcoming slides. So to see the spectrum of spondyloarthritis, mainly it is divided into axial or peripheral. In axial, usually it will involve spine and sacroiliac joint. Whereas in peripheral spondyloarthritis, it will involve the joints of lower limbs mainly, or there might be involvement of some other appendicular joints of upper limb. But it is not a rule to present it in the similar way. Why is it named axial and peripheral is because the maximum involvement will be of axial skeleton in axial spondyloarthritis, but there might be chances of about 30 to 40% cases having associated peripheral skeleton involvement as well. Similarly, it will apply to this one. It is not a rule to have only appendicular skeletal involvement. In these peripheral spondyloarthritis also, we can see axial skeleton involvement, but it will be to minor extent. So based on the predominant presentation, we will label it as axial or peripheral spondyloarthritis. And in axial, again it is divided into radiographic or non-radiographic axial spondyloarthritis. So it is mainly based on the radiological features which they will divide again. We can say in simple terms, it is just the progression. That is, initially the individual might not be having any radiological features. So they are termed as non-radiologic axial spondyloarthritis. So here mainly the sacroiliitis grading of grade 1 or grade 2 unilateral are considered in this group, and as the disease progresses to involve further higher grade of involvement in sacroiliitis, for example bilateral grade 2 or grade 3, grade 4 and all are included in radiographic axial spondyloarthritis, and the advanced form is called as ankylosing spondylosis, whereas peripheral spondyloarthritis will involve a spectrum of other variants like psoriatic arthritis, where along with the skeletal tissues we will see the involvement of skin and nail. So here we have to know the important features of psoriasis as well, or take the help of dermatologist to find out psoriatic condition when we are evaluating the case of inflammatory arthritis. And it might be inflammatory bowel disease associated peripheral spondyloarthritis. It can present as Crohn's disease or ulcerative colitis. So look for the features of these conditions. Or it can be reactive arthritis after the infection of genitourinary tract with chlamydia, or commonly gastrointestinal infections like Salmonella, Shigella and Campylobacter and all. The individual might develop peripheral spondyloarthritis. Commonly, the time gap between the infection and development of this arthritis will be 1 to 4 weeks. And if it is not fitting into any of these particular conditions, they call it as undifferentiated peripheral spondyloarthritis. Sometimes this spectrum will also include Sappho syndrome, that is synovitis, acne, pustulitis, hyperostosis and osteitis, or it might be arthritis associated with acne or some other skin conditions. That's why whenever we think of spondyloarthritis, always look for those 3 extra-articular tissues involvement, that is skin, kannu and intestine. Now we have understood numerous features for rheumatoid arthritis as well as spondyloarthritis, but to definitely consider the diagnosis, they have claimed numerous criteria. For example, for rheumatoid arthritis, the ACR-EULAR criteria is helpful, where based on the involvement of joints, serology, acute phase reactants and the duration of symptoms, we will be giving some scores, and if it is more than 6, it will fulfill the requirement of definite rheumatoid arthritis. So this criteria we have to apply. Similarly, for ankylosing spondylitis, that is radiologic axial spondyloarthritis, again there is modified New York criteria. For example, it will involve some clinical features like low backache for more than 3 months, which will improve with exercise and not relieved by rest, limited lumbar motion, reduced chest expansion, and radiological supportive evidences like bilateral grade 2, 3 or 4 sacroiliitis. So we will say definite ankylosing spondylitis only if there is more than 1 clinical criteria and 1 radiological criteria. And when it comes to the diagnosis of psoriatic arthritis, there is something called as Casper criteria. Again, here scores are given based on psoriasis features, the nail changes, and there should be negative RA factor. There might be predominant involvement of the digit presenting as dactylitis, and there should be radiographic evidence. So based on all these, again, we can fit the case into psoriatic arthritis. So these criteria are important for confirming the final diagnosis. So whenever you are suspecting any particular condition, just try to follow the criteria. And we can take the help of some other investigations as well. For example, acute phase reactants, ESR and CRP might be elevated often, but they can be normal in about 10% of the patients. And if it is monoarticular kind of presentation, commonly in peripheral spondyloarthritis, we can send for synovial fluid analysis, and it should show the inflammatory picture. That is, WBCs ranging from 5,000 to 50,000 cells, mainly involving neutrophils. So why is it important to do synovial fluid analysis? It is crucial to exclude infectious or crystal-induced arthritis like gout or pseudogout. And we can take the help of joint imaging like X-rays, MRI, which will detect active inflammation or edema, and it will be helpful quite in the early stage to diagnose, or ultrasound of the joint, which will detect increased vascularity, which is again a feature of inflammation. Based on the extra-articular system involvement like lung involvement or cardiac involvement, we can order that particular system-specific tests. So now we have diagnosed the condition by fitting into all these features and taking the help of numerous investigations. Now we have to know how these diseases will progress. For example, rheumatoid arthritis patients, in about 10% of the individuals, we will see spontaneous remission in about 6 months. Especially, as I have mentioned, the seronegative RA patients, they will have spontaneous remission in just 6 months. So no need to intervene much. But about 90% of the patients will have persistent progressive disease, where we will see waxing and waning type of presentation with some acute flare-ups in between. So because of this persistent progressive disease, we will be able to see the hallmark skeletal changes like bone erosions, osteoclast activation, and there might be synovial tissue inflammation leading to pannus formation. There will be destruction of articular cartilage as well as bone, leading to reduced joint space. And because of this progressive disease and involvement of steroid as a therapy as well as disability mediated immobility, the individual might lose bone tissue leading to osteoporosis as well. And in especially rheumatoid arthritis, as mentioned, because of cervical spine involvement, the individual might develop compressive myelopathy. So this is the probability of disease progression in RA. Whereas in spondyloarthritis, as you know, it will progress from non-radiological axial spondyloarthritis to radiological evidences. That is, gradual changes in the sacroiliitis. So what are those changes? We might see erosions, sclerosis, and finally leading to partial or total ankylosis. And one of the pathological hallmark of spondyloarthritis is, in this condition, we will see the coexistence of bone erosion as well as the new bone formation, leading to spur kind of appearance, which we call as syndesmophytes, and these are vertically oriented. And because of these syndesmophytes, there might be one of the famous hallmark feature if it is particularly involving spine, that is bamboo spine. So you can see in this particular image, these are the syndesmophytes. Whereas in psoriatic arthritis, the disease might progress to involve enthesis, causing enthesitis, and we see marginal bone erosions with fluffy new bone formation. And another hallmark feature is pencil in cup deformity. But in this particular condition, the syndesmophytes are not marginal. They will be commonly present at the site of attachment of these tendons or the sheaths covering tendons and all. So it is not usually marginal. And finally, it might distract the articular tissue leading to arthritis mutilans. So here in this particular image, we can see there is bone erosion as well as fluffy new bone formation. And this is marginal bone erosions, again a hallmark feature of psoriatic arthritis. And the image on left side, here we can see the pencil in cup. This is pencil kind of appearance in cup deformity, which is again the hallmark feature seen in psoriatic arthritis. So once we have diagnosed these conditions, now we will see how to treat. Mainly, the goal should be early aggressive treatment so that we can prevent the joint damage which will happen if not intervened early. Always aim for lowest disease activity or the clinical remission. So there are numerous scores to assess the disease activity, and there are some criteria to call it as clinical remission. We have to calculate those scores and start treatment and try to improvise in that particular score. So what are the steps we will follow? Mainly, for symptomatic control, we will take the help of NSAIDs and steroids. And as foundational initiation therapy, we will take the help of conventional synthetic DMARDs. And for escalation, we might utilize biological DMARDs or targeted synthetic DMARDs. And finally, if the individual is not responding, we label them as refractory case, and for that also the management will differ. So all of this we will discuss. Coming to the symptom control, mainly we will take the help of NSAIDs. So they act as adjuvant therapy for symptomatic control, and among NSAIDs all medications are equivalent. So we can try in that particular patient, and based on the response we can continue that particular NSAID. There is no selectivity in this particular class, and the rule is do not use NSAIDs for long term to avoid the well-known complications of NSAIDs. Coming to glucocorticoids, first of all, always prefer the low dose prednisone, that is 5 to 10 mg per day only. High doses are reserved for rheumatoid arthritis related ILD conditions. And remember, steroids are not helpful in spondyloarthritis, particularly in case of axial spondyloarthritis. So when to utilize glucocorticoids? Mainly when we plan for initiation of DMARDs. Remember that they might take quite a longer time of about 3 to 6 weeks to manifest their effects. So in that time gap, we should take the help of glucocorticoids for the disease control. Otherwise, whenever there is acute flare-up of the condition, for 1 to 2 weeks duration, we can take the help of glucocorticoids. One more indication is when there is inadequate response for DMARDs, alongside DMARDs, we can utilize glucocorticoids. But remember, the chronic use should be strictly avoided because of, again, the well-known complications like osteoporosis and all. So steroids mainly indicated for 3 situations. One is for acute flare-up. Second one is till the action of DMARDs sets in, we can take the help. Otherwise, we have started DMARDs, but there is quite inadequate response. To fill that gap, we can use steroids, and it should be always low dose steroids. So this thing I have mentioned. Initially, for rapid disease control or symptomatic treatment, we can take the help of these 2 groups. But the important therapy is the disease modifying agents. But only drawback is they will take minimum 3 to 6 weeks for the action to set in. So till then, we should take the help of the symptomatic therapy to cover that pharmacological gap. Coming to the DMARD of choice, that is Methotrexate, usually 10 to 25 milligram per week, either orally or subcutaneously, it is advised. And always we have to add for folic acid 1 mg per day to minimize the toxicity. What are those toxicities? Commonly we will see hepatotoxicity, myelosuppression, and interstitial pneumonitis as well. So it is important to monitor the patient with CBC and LFT every 2 to 3 months. And this drug will not be helpful in case of pregnant females who are having rheumatoid arthritis, as well as it is not helpful in case of axial spondyloarthritis. And when we initiate methotrexate along with folate, observe for 3 to 6 months. If you find it ineffective or there is no proper response, we have to shift to the combination therapy. So what are those combination options? One is called as triple therapy combination, where we will add methotrexate along with HCQ, hydroxychloroquine, and sulfasalazine, or methotrexate plus leflunomide can be utilized, or directly we can go ahead with methotrexate plus a biological DMARD. So after initiation of methotrexate monotherapy, wait for about 6 months to look for the response. If you feel it is inadequate, then we can go ahead with the combination therapy. So just few points about other conventional DMARDs like leflunomide. It is almost similar to methotrexate when it comes to the adverse events or the efficacy. Only difference is the dosing, where methotrexate is advised once weekly, whereas leflunomide should be everyday medication. Coming to the other conventional DMARDs, that is hydroxychloroquine, it is being seen that it does not delay the radiological progression of the disease. So many will not consider it as a true DMARD. But still, we can choose this particular medication in early and mild disease or as adjuvant therapy along with methotrexate and sulfasalazine as a triple combination medication, and the dosage is 200 to 400 milligram per day orally, and it should not cross 5 mg per kg per day. But the important thing is there might be irreversible retinal damage or cardiotoxicity. So every year eye examination, again efficient as an adjuvant therapy, and we have to monitor for CBC because granulocytopenia is one of the adverse events with sulfasalazine, but it is also considered as safe during pregnancy. Coming to the biological DMARDs, mainly anti-TNF agents, which can be remembered using the famous mnemonic, that is ACE inhibitors ko goli maru. So A stands for adalimumab, C for certolizumab, etanercept, infliximab and golimumab. But whenever you are thinking of biological DMARDs, always screen for infections like hepatitis B, hepatitis C, and look for latent TB using tuberculin skin test or IGRA. If it is positive, we have to treat latent TB for 1 month before initiation of these biological agents. Similarly, particularly for rheumatoid arthritis, anti-IL-6 agents can be utilized like tocilizumab and sarilumab. These are effective as monotherapy as well as in combination with the conventional DMARDs. But again, the adverse events likely there will be increased infection risk, cytopenias, dyslipidemia probability and GI ulcers. So these things should be kept in mind. Coming to interleukin 17 inhibitors like secukinumab, ixekizumab and bimekizumab. These are mainly helpful for spondyloarthritis like axial spondyloarthritis and psoriatic arthritis. But remember, it should be avoided in IBD associated arthritis. So for intestine, we can say this 17. Satra is having khatra. But for other spondyloarthritis, mainly involving the axial skeleton, it is a very good drug of choice, we can say. Similarly, for interleukin 23 inhibitors, these are the examples. This ustekinumab is particularly interleukin 12 and 23 inhibitor. So we used to remember this ustad can come at 12 o'clock or at 24 o'clock. So as he is the ustad, time doesn't matter, 12 or 23. Again, this is used only for peripheral spondyloarthritis and it will not work for axial spondyloarthritis. So in the spectrum of spondyloarthritis, though there are many overlap, there are also dissimilarities. That's why few inflammatory cytokines are involved in one particular spectrum and few of the agents will not work for the other pattern of spondyloarthritis. Coming to the targeted synthetics, mainly JAK inhibitors, the examples are tofacitinib, baricitinib and upadacitinib. Commonly, tofacitinib 5 mg twice daily per oral can be utilized. And again, these are beneficial as monotherapy or in combination with methotrexate, particularly when the biological DMARDs like TNF alpha inhibitors fails, we can shift to JAK inhibitors. The added advantage is these are oral medications compared to the injections or infusions of biological DMARDs. But remember, they have numerous adverse effects like neutropenia, transaminitis, elevated creatinine, hypertension, dyslipidemia, leading to thrombosis, major adverse cardiovascular events, even the risk of malignancy will be increased. So all these points should be remembered, not just because it is a oral feasible medication, we will directly go ahead with this particular class. So after conventional, if we see in biological versus targeted synthetic DMARDs, the infection risk is almost similar in both of these conditions, but the other adverse effects will vary and the route of administration will also a differentiating point, we can say. Now whenever these biological therapy fails, what we have to do? If there is primary failure, that is when we have initiated some biological agent there is no benefit seen at all. That is called as primary failure. So in that case, we have to change to some entirely different biological agents. For example, you have started with TNF inhibitors and there is no benefit at all. In that case, switch to interleukin receptor inhibitors and all. And the reverse way otherwise. Whereas in secondary failure, where the individual is benefited initially, but now there is no adequate response. So this is failing after initial benefit. In that case, we can choose some other drug from the same class. For example, you have started with adalimumab, you have seen the response, but after some time the response has stopped. So in that case, from the TNF alpha inhibitors group only, you can choose the other medications like golimumab or infliximab. But suppose after initiating the combination therapy as well, if the individual is not responding, we label them as refractory rheumatoid arthritis case. Particularly when there is failure of this methotrexate plus biological DMARD combination, we can take the help of reserved drug, that is rituximab. Again, there will be increased chances of infections, but the claimed progressive multifocal leukoencephalopathy risk is actually very low. And always remember, in relation to biological DMARDs, in very active musculoskeletal disease, you can directly initiate these agents. And the biosimilars are fully validated and may be used in place of original biologics. These biosimilars will be having the active compound which is just like the original biologicals, but the adjunctives might differ, benefiting in the cost effectiveness. And double biologicals are illogical due to very high risk of infection. So never combine two biological agents. And their role in pregnancy is not having sufficient data. So if the individual is a case of inflammatory arthritis and is pregnant, avoid biological DMARDs. And in that case, as mentioned, the conventional ones like HCQ or sulfasalazine are safer. And whenever you are treating and following up the case, always try for the complete remission. So particularly for rheumatoid arthritis, they have defined the meaning of remission. That is, there should be less than one tender joint and less than one swollen joint. The CRP level should be less than 1, and patient's global assessment in the scale of 0 to 10, it should be 1 or even less. So if this patient has achieved all of these, then we can say that the patient has achieved clinical remission. Or simply, we can take the help of disease activity scores, especially SDEI, Simplified Disease Activity Index, where if the score comes as less than 3.3, you can label it as clinical remission. Finally, to summarize, we will just see the differences between rheumatoid arthritis and spondyloarthritis. So rheumatoid arthritis is common in females. It will present as symmetric polyarthritis involving small joints, and pathologically we can see pannus formations and erosions. And the key biomarkers are rheumatoid factor and anti-CCP antibodies. The hallmark deformities seen in RAR, swan neck deformity, ulnar deviation and all. And the systemic manifestations will be nodules in the lungs or secondary Sjogren's. Whereas for spondyloarthritis, it is quite equal or more in males compared to females, and commonly presents as asymmetric oligoarthritis involving axial or large joints of lower limbs. Enthesitis, dactylitis are all the hallmark pathogenic manifestations in spondyloarthritis, and new bone formation coexists with the bone erosion. And the key biomarker will be HLA-B27, though its mere presence will not dictate the individual as having spondyloarthritis, but it is a strong genetic risk factor as mentioned. And the hallmark deformities are bamboo spine in case of ankylosing spondylitis, whereas penicillin cup deformity in psoriatic arthritis. And the systemic manifestations are again skin related psoriasis, eyes related uveitis, and intestine related IBD. Just to give the flowchart for management of these cases, always start with NSAIDs. Up to 4 weeks you can utilize these for symptomatic control. Steroids only if indicated, and initiate the methotrexate along with folate. And remember, it will take 3 to 6 weeks for its effect. That should be explained to the patient. And once started on this CSDMARD, observe for 3 to 6 months. If there is inadequate response, start with combination therapy. You can choose triple therapy, or directly we can add biological agents among TNF inhibitors, interleukin mediated medications, or the oral JAK inhibitors. And once you start on this combination therapy, if there is primary failure, switch between these classes. If there is secondary failure, choose some other medication from the same class. And even after this combination therapy, for about 3 to 6 months, if the individual persists to have rheumatoid arthritis features, we label them as resistant case and take the help of rituximab. And whenever we are treating the individual, always keep an eye on CBC for cytopenias, LFT for hepatotoxicity, and superadded infections. This should be followed up every 1 to 2 months. So this was the elaborate discussion about inflammatory arthritis. Hope you have understood the entire lecture.